Your presentation begs us to ask the question about availability of medications to control asthma in the United States, right, in our low and middle income communities. And whether this is more politics perhaps than social policy, but do you have any thoughts about how to make affordable quality medications available to patients in our society who might not be able to pay?
Well, yeah. Well, this is the key question that we hear around the world. It's not just the United States. It really is important because the medications are so expensive, and people just laugh when they see some of the medications listed in our documents. But you know, you talk to some of the people in the lower countries, and they said, just keep putting those medications on your list, because if they're not on the list, then we'll never get them. And if we can, I think that's what's important for us to begin to show, is that if you can decrease the cost of care and put that money instead in medications, you can keep people at work and you can keep people at home. And it is working. I think in Vietnam, we'll be there next week. It turns out that the Minister of Health of Vietnam is married to the head of the respiratory unit in Hanoi, which really helps. But they're very interested in this concept, and I think it's very good because I think if you can convince people up there that providing medications, and the information from Finland is probably the best example. But this country is so vast, and the healthcare system, you know better than we do, so complicated that I'm not sure I have a good answer. I don't know whether, I think, let me just say is that, again, I showed you that the Healthy People 210 program identified asthma as being a target. That's an essential step. And I understand that the 2020 program also targets asthma. And these are the kind of things that you probably don't even, I probably could care less about, and probably have many more important things to do. But that's the type of things that they do, I think, at NIH, is that they're really keyed into realizing the importance of making these programs visible. Because without the visibility, you don't get the support. So, yes.
I have a question, but I have a comment first. I want the audience to realize that there are two people present today who participated with me. One is Chris Fanta, who helped write the original guidelines, and Jeff Drazen, who is helping you currently, which you mentioned. Now, my question, quite frankly, in 1985, I was a little more optimistic about how we were going to treat asthma. And I thought with the recognition of inflammation, as central to the asthma as we move in, with appropriate therapy, this would be eradicated by now. What was particularly disturbing to me was the slide of the United States. In the pediatric group, there's been no change in the incidence of mortality and morbidity. And that's
discouraging.
It's not just because of the cost of drugs. I realize that's a factor. The other problem is we're missing something. And I think that we're not educating our patients. Asthma is a disease that the patient must take care of. You must have a doctor available, but it's a patient managed disease, and I don't think we're accomplishing that.
Well, just to answer that, I was very impressed with that one slide that I showed where asthma self-management programs are given only to 34% of the people, which is really very low. That turns out to be one of the first things they generally do in most of the other countries, is to develop the plan that's localized. It doesn't have to be the GINA plan or the NAEPP plan, but something that translates and works well within the environment in which you're in. And many of them take these documents, but I think the translation and the understanding and how patients use them I found very surprising that it's such a low percent here. So those kind of interactions probably would help. Yeah.
Can we say good morning to our colleagues at the Cox 2 conference room at Mass General and invite you to, hi there, invite you to ask a question. It would require, I think, unmuting the sound. And if you have a question, please feel free to ask it.
No questions, thanks.
Okay, thank you. Elliot, do you want to use the mic?
Sue, I think this work is a wonderful follow-up to your work at the NHLBI and really taking it global. And I think it's clear that you're making an effect, and obviously also clear that there's still a long ways to go. In that regard, I wondered if you've thought about the question of whether, now that there's more and more data suggesting that for at least mild or moderate asthma, PRN inhaled corticosteroids work just about as well as regular. Whether if we talk about simplifying, and actually both at the patient level and at the physician level, has there been thought to actually thinking about promoting that? It saves cost of medication. It's much simpler for the patients to understand in terms of what they do, and especially for these areas where medications are an issue, might actually allow better implementation.
Okay, I think I could probably safely say that in many countries that's exactly what they do. I've been told that in Denmark and in Finland and many of the northern countries that's all they do, is just give the inhaled corticosteroids and they work. Patients are kept out of the hospital and patients don't die. But I think in many other countries there's maybe, I don't know, politics involved or whatever, but it's a little bit hard to make a blanket statement like that in a global document. We have to be very careful to make sure that we're giving a series of options. And I think it's up to the local people then to implement what's going to be effective in their patient population. So we have to be a little bit careful to be as inclusive as possible. Of course, we are very careful to make sure that all of the literature that we read, and Dr. Drazen can tell you we go through everything twice a year, all of the publications. So anything that comes out that might be a good new effect once it's published, we try hard to do. But again, one of the things that I should have pointed out is that we call our document a global strategy for asthma management and prevention. So we don't call it a guideline, we call it a strategy. And I think that's an important concept because we don't want it to look as if we're prescribing medications. We're providing a kind of an overall framework for people to use within their own local healthcare setting. So I know I didn't answer your question, but I think it's important for us to provide options, especially in many low developing countries. Some of these people just have no access to these kind of medications, which is, by the way, one of the advantages of that asthma drug facility, because they are able to come out with inhaled corticosteroids. They're working very hard towards getting some inhaled corticosteroids available. It's also an important part of the World Health Organization because they need to put some of these medications on their essential drug list. And until that happens, many of these countries just aren't going to use them. So it's all tied up into politics very much. Jeff maybe remembers the essential drug list discussion even way back in 1995, where at that time WHO had no medications on the essential drug list for asthma. And they now at least have a corticosteroid, but we need to work at them to get an inhaled corticosteroid. All of these things are just more pressure can be put, the better it will help.
Fascinating talk. Can you get a sense from the implementation of these guidelines in other countries as to how much of the impact that they've had has been due to the introduction of the medications versus some of the other non-medical treatment strategies, be it allergen avoidance and so on, and how do those differ around the world? Because some of the allergens are quite different, and some of the things you might do might be very different.
Well, it's a good question. I haven't looked at it that way, but maybe I would look at it that way. I would go back and look at some of these countries and see. I think that my first reaction to your question is that it's all of the above. I think that the medications are important, but that people have to understand what is their asthma. They have to try to avoid the risk factors. In Vietnam, it's almost impossible to avoid many of the risk factors. The indoor pollution, all those motorbikes, the pollution is a terrible problem. So to try to, I think people are aware of those, but I think in that case, the medications may be the most important. But again, I haven't looked at, I think it's an interesting thing to look at. The Finnish data may be the best to look at that, comparing the Finnish data with some of the other implementation. I know that they've taken the Finnish model and they're actually now implementing that in Ireland. There's a very active person in Ireland who's working, again, a countrywide initiative, very similar to the Finnish one. It's working with the Ministry of Health people there. It's targeted to all the asthma clinics throughout Ireland. So that may be another good model to see, is how that works compared to Finland, and to answer the question that you just asked me. Because it's being done through the ministry, they will have access to medications being given to all of the clinics. So that's very good. Okay, well, thank you very much. Thank you very much for inviting us.